getting this done despite being unwell from Delhi. It's my pleasure to introduce to you Dr. Adit Gupta. Adit is a double fellowship certified oculofacial plastic surgeon, both from certified from India, from LVP, LV Prasad Eye Institute, my alma mater as well, and from Dr. Bob Goldberg. Adit is in practice in Mumbai. Over to Adit.
Hi, thanks, Debraj. Sorry, I'm still catching my breath, but just before we begin this talk, a show of hands as to how many people inject Botox already. Good, and how many want to? Everyone, so that's good. Since Shilpa has already made my job easy, she has already spoken about the anatomy in depth, I'm going to speak about the practical aspects of injection and how to choose your patients for botulinum toxin injection. So we all know, or we should rather know, that botulinum toxin was first invented by an ophthalmologist and not a dermatologist. It was an ophthalmologist-dermatology couple, Jean and Alistair Caruthers. So we should be proud of that fact that an ophthalmologist was the first one to use Botox. And even before they used it for spasms, another ophthalmologist used it for strabismus. So history of Botox dates back to ophthalmology, so we should regain that territory. Although we all know about the functional aspects of botulinum toxin injection, what we'll be focusing on are the cosmetic aspects. And for that, even before you inject, injecting is not a very difficult job. Understanding the psyche of the patient or understanding what the patient wants gets the patient back to you when you perform these injections. Injections can be done even by your nurse. So more than injections, it's the evaluation of the patient that matters, and it should be a holistic evaluation. So it should not be just like, oh, I'm going to inject your eyes. You have to look at the whole face and maybe cover other areas than what your training taught you during your residency. So you should look at the skin quality, you should look at the fat pads, you should look at the contour of the bones, you should look at static as well as dynamic wrinkles, as you see in this nomogram which I've shown here. Once you have convinced your patient, you should also use your words with caution. You cannot be rough with these patients. You need to avoid certain words and use more words and create an ambience so that these patients like to visit your clinic, very similar to how you deal with a LASIK patient or a premium IOL patient. Now, this is a small video which shows how I evaluate my patients. So if you look at this gentleman, when I do a Botox injection, during the first consultation, I always ask the patient to show all possible range of movements on their face. So if we focus on the upper face, you see how the patient is asked to frown and raise their eyebrows so as to delineate all possible muscles which we need to work on. After that, I apply an EMLA cream or a prilocaine cream, which constitutes of prilocaine as well as lidocaine. This is a topical anesthetic solution which penetrates into the epidermis and the dermis and numbs the skin to a certain extent. This also acts like a placebo in many of the patients because you don't want to scare your patient, especially on the first visit. So this cream is left in place exactly at the points, or you can apply it like a sheet, following which an occlusive tape is used so that the cream penetrates into the dermis faster. So once this cream is applied, you can either spread it with a spatula or with your gloved fingers and then apply this occlusive tape which comes within the packaging of the cream. This occlusive tape usually helps in penetration, and so the wait time is less. So if you use this occlusive tape, you can inject the patient after 30 minutes. If you don't use it, you have to wait at least for 45 minutes to an hour before you inject. So these are small tips that help you in your practice to convince the patient. Now, focusing on the muscles that we'll be learning to inject on, the most common muscles for us are the orbicularis, the frontalis, and the eyebrow complex of muscles, which includes the corrugator, the depressor supercilii, and the procerus. Apart from that, obviously, you can expand your indications once you're more confident with these group of muscles. But as a rule, usually we try to avoid botulinum toxin injections in the mid-face area, except for certain specific indications or with very advanced training, because this is the most dangerous area for injecting botulinum toxin because it can cause very evident lip asymmetry. There are different molecules of Botox available in the market. Botulinum toxin by Allergan was the first one to be introduced, following which a flurry of products came, like Nabota by Dr. Reddy's, Botogini, which is one of the cheapest available forms of Botox produced by an Indian company, and then there are different Korean brands available as well. I have personally used 2-3 of them, and I don't find very much difference in the efficacy. These came now because the patent which was with Allergan for 20 years has expired, so now a lot of companies are getting the botulinum toxin molecule. Now, for dilution, you should usually use 0.9% saline, which is non-preserved because it leads to lesser pain while injection. If you use distilled water by mistake, you can evidently make it out. The patient will scream and shout because it's very painful if you dilute botulinum toxin with distilled water. Concentration can be modified according to your need. I prefer a concentration of 4 units per 0.1 ml. Some people prefer 2.5. Some people who want to do a concentrated injection even dilute it to 10 units per 0.1 ml. It can be stored. Ideally, the company says you have to use it within the same day. But I have noticed that you can use it for up to 4 weeks if you store it in the lower compartment of your refrigerator. Some of my friends vouch that they've used it with same efficacy for 3 months as well. No special precaution is required, but you should not be too jerky while handling the molecule because it is very sensitive to touch and even temperature. This is a very good practice to follow in your clinics. This chart is easily available with the dealers that supply you Botox. So you should ask them for this chart so that you can chart exactly where you're giving the injection so that the repeatability, if the patient is happy with your first injection, you want to do it again and again at the same spot so that you don't have variations because it's a very sensitive molecule. Even a 2 or 3 millimeters here and there can give different effects with the different group of muscles. So this chart is very good, which I follow. And then obviously I stress more upon consent nowadays because we usually tend to not take consents for minor procedures in our busy practice, like Chalazions, Botox. We should be taking consents because every injection which you do can have potential lethal complications as well. Now let's come to certain subgroup of muscles which we deal with. Let's go to our favorite area, which is also the best area to begin with for a beginner ophthalmologist, is the crow's feet area. Crow's feet is nothing but condensation of the orbicularis muscle, which is like a strap muscle. Origin is at the medial canthus, rotates around the lateral canthus and goes back to the medial canthus. So there's no insertion at the lateral end, but it's like a sphincter muscle there. For starters, usually we begin with 10 to 12 units and go up to 30 units in bulky muscles. And you see they radiate towards the temple area. So sometimes if you have too much radiation, you can inject more points as seen here. As a rule of thumb, you should not go beneath the zygomatic arch. And while injecting, for a beginner, your hand should be within the orbital rim so that you don't inject too close to the eyeball. Sometimes diffusion into the lateral rectus can cause transient paralysis and diplopia. All these effects are reversible. So usually, as I said, around 12 to 30 units, 6 units each side. Start with 2 to 2 units at each spot, and then you can go higher depending on the effect that you get. This is a short video which shows injection of the lateral crow's feet area and the eyebrow complex. This is how the orbicularis origins and inserts. So you see it goes all around. So I use a 30 gauge needle. 29 gauge is good enough. Now 31 gauge is also available. And a 1 cc syringe because the resistance is less and easy to calibrate. Once you're experienced, you can inject with the needle pointing towards the eyeball or the orbital rim. Otherwise, you can go in a different direction away from the eyeball if you're not confident. As a beginner, you should keep your hand within the orbital rim, as I said, and then you inject at 3 points depending on the radiation. So this patient doesn't have too many radiations of the crow's feet. Sometimes a lot of people also add a little unit to the lower part of the lateral eyelid just to take care of the orbicularis roll. So this is the crosses marked in red are the area to be injected and the blue ones are to be avoided. Although with experience, you can go there as well with micro injections. Now coming to the eyebrow complex, mostly we have the medial depressors of the eyebrow and the lateral elevators, and the frontalis acts as an elevator and the orbicularis again as a depressor. But what we target is the medial depressors, that is the corrugator. Now corrugator is of varying lengths. If you see, it has a long tail in some people, and so you need to go a little more laterally, but you should not go beyond the mid pupillary line as it will cause a paradoxical depression. So this is how usually the procerus, the corrugator and the depressor supercilii are. So depressor supercilii is not seen very prominently in all cases, but especially in celebrities, if you see Shah Rukh Khan's eyebrow, he has a very prominent depressor supercilii. And then you target the lateral part of the eyebrow, which basically consists of the orbicularis oculi muscle. So you can go within the eyebrow hair as well, because this is the arch lift that mostly women want, and the tail of the eyebrow as well, which again gives a nice subtle elevation to the lateral part of the eyebrow. So you see, it's so comfortable for the patient. Hardly they wink, squeeze or anything if the injections are done in a good manner. And the needle should be replaced after every 6 or 7 pricks, because that is the sharpness of the needle stays up to that level. This is the last muscle which is being injected, the procerus, which you can hold within your thumb and fingers and then inject in the belly of the muscle because it lies a little deeper than the orbicularis muscle. But not all crow's feet or not all wrinkles need Botox. So this old lady, if you see, she also has crow's feet. But these are mainly because if you look at the eyebrow position, the eyebrow is very depressed, right? If you see, this eyebrow is almost gone, this is the orbital rim, and the eyebrow has gone beneath the rim, because of which the skin gets redundant, and this is a pseudo crow's feet. Basically, these are static lines which cannot be. So if you inject Botox in this by mistake, she's not going to get a very good result. Now coming to forehead, which is also a very easy area to inject, but an easy area to go wrong as well, because if you give a frozen appearance, not many patients like it. You need to know the anatomy of the frontalis muscle very well. Frontalis can be bifid, it can be a unilateral sheet-like muscle, and you need, as a rule of thumb, you should avoid around a centimeter's area from above the eyebrow, because then you can, the injection can get diffused in the eyebrow muscles and can cause adverse effects and depression of the eyebrow and a pseudotosis appearance. So this is the effect that you can get by injecting uniformly along these points. Depending on the diffusion capacity of the molecule, you need to space it out, and sometimes some people also like to do watercolor injections. But to begin with, in women, 10 to 15 units is a good dose to cover the frontalis, and in men it requires more dose because men, the forehead is thicker and the muscle needs more injections. So 20 to 30 units is a good starting point for men for the forehead. There is a new technique which is also called as baby Botox or micro droplet Botox, where you dilute the Botox to a higher, to a very low concentration, and then inject very fine points all along the forehead. So you can keep injecting all around the forehead. As the concentration is less, you don't get that frozen appearance. This is very good for people who want to maintain some part of their animation, especially newsreaders, actors, models who want that. Now, we already spoke about the eyebrow and the complex, but these are general injection points which you can follow for the procerus, the depressor supercilii, and the corrugator muscles. Usually when I inject, I ask the patient to frown so that I can exactly delineate where to inject. And then this is the standard dosage followed for a young lady. 4 units in the procerus, 4 units in the belly of the corrugator, and around 2 to 3 units in the tail of the corrugator, which gives a nice subtle elevation as you see in the pre and the post pictures. Now, as I said, usually starting dose for the eyebrow complex is around 20 to 30 units in women and 30 to 40 units in men. This is the consensus guideline which has been published already, so I'm not creating it on myself. And then exaggerated glabellar lines, as you see in this lady, again, Botox is not going to do the job completely, but it is going to give you a softening effect, which then later on the static lines can be covered by injecting filler in this area, although it is a little dangerous. Botox can also be used to augment surgical results, as in this lady who underwent a blepharoplasty. You can see I have excised a little bit of skin from this area, and she gets a good decent result. We can see the tarsal platform now, but you see there is frown line still and the eyebrow is a little depressed. So you see with Botox at these particular points, you see you can lift the eyebrow and augment the results of a blepharoplasty. So these patients are happy, and you can give them a complimentary Botox after 2 weeks so that they keep coming back to you for Botox as well. It can also be used to adjust the eyelid fold. So if the eyelid fold is asymmetrical, which advanced training, you can see that this eyelid fold is higher. This eyelid fold after injection becomes a little lower. This is by injecting in the frontalis so that this eyebrow goes down, and contradictory, you lift the other part of the eyebrow. Now, although Botox is known to cause ptosis, we can also treat a very mild amount of ptosis with Botox. The mechanism here is that you inject in the orbicularis, which is a closing muscle of the eye, and the paradoxical muscle, that is the LPS, acts unopposed when you inject in the orbicularis. But you have to be in the pretarsal part of the orbicularis. You cannot be in the preseptal part, because otherwise it will cause ptosis again. So you inject exactly at that point, and then that causes maybe a 0.751 millimeter lift. Last but not the least, with eyebrow Botox, you have to be very careful because there can be imbalance as seen in this lady. And then you inject this POC point and treat the lady for any side effect. So lastly, I would like to conclude that look at the patient as a whole. Don't just treat the eyes. Go ahead and inject in the forehead, in the lower face, inject fillers, do everything that you can to look, make the patient look holistically a better person. And obviously the point driven here is that Botox is not to have similar expressions for all expressions on the face. So your injection techniques have to be very subtle so that patients can express and emote after injecting Botox. Thank you.